Thank you, Jayanta, and my humble gratitude to GVK for this honor and opportunity. My today's talk is on insulin therapy, errors and precautions. Fortunately, we already had two sessions which were focused on common barriers in diabetes therapy, and there were some important areas which have been even spoken by Dr. Ramachandran. So my job is little simple and easy, and next maybe 20 minutes I'll try to justify the presentation. So thank you, Dr. GVK, and of course I invite every one of you for the 19, 20 and 21st of June at Nagpur for Hello Diabetes Academia. And of course, I'll forget in my duty if I don't invite you for the National RSSDI, which is on 19 to 22nd of November at Bengaluru. And on behalf of our President, Dr. Anuj Maheshwari, our Secretary, Dr. Rakesh Parekh, Dr. Prasanna Kumar, Dr. G. Srinivas Murthy, our EC member, Dr. G. Vijayakumar here, and we have our Vice President also here somewhere. I saw him. We have Lotika, our EC member from National EC, Jayant Panda, and if I'm forgetting some name, yeah, our treasurer, Dr. because every time I forget some other, Pratap Jetwani. So on behalf of every one of us, I invite all of you, so kindly block your date, and believe me, the team is really working hard to help you out and involving most of the people, many of the people from Tamil Nadu state also. No conflict of interest for this particular session. What do you mean by medication error? Medication error is any preventable event that can cause or lead to inappropriate medication use or patient harm while the medication is in control of the healthcare professional, patient or the consumer. Avoiding such errors in insulin treated patient is critical and it's important for the therapeutic success. Otherwise, you will be taking insulin, but if it doesn't work, or if it works and causes further hypoglycemia, or if precipitates some local injury, that is of course to be, which is avoidable, preventable. Such errors in insulin therapy can potentially arise at each and every step, starting from the office of the clinician writing a prescription till it reaches to the patient being used. So we'll have some insulin prescribing preventable error, because this question was asked to Dr. Anil Virmani that time, and I stopped that question. I said that's going to be covered by me. So insulin prescribing errors, which are preventable errors, and we'll try to see the solution. Very practical thing. Just you imagine your own practice. Try to see that someone is coming writing a prescription. What can happen if I am not focusing on that? And what others can be, where others, if you're not doing mistakes, some of your other colleagues or family physicians might be doing it, how can we correct it? Errors in the insulin technique, their consequences and prevention, and some important stories if I can manage it. Now, how prescription error is also very common, around 37% with type 1 diabetes, almost 40% with type 2 diabetes, and this is not Indian data, this is British data, UK data. If it can happen to a developed country like UK, then it can happen to anyone. So this is data from type 1, type 2, these are insulin, diet only, non-insulin. So multiple errors can occur, and that has been documented. Insulin in prescription error in India, there are around 7 different companies supplying insulin in various forms. We know that. And availability of the human and analog, their type, their different formulation, it could be regular, NPH, Lenti is not available now, 30-70, 25-75, 50-50, it's the complexity. Error involved in timing of the insulin dose. People, 90% of the patient, you tell them if they are not gone to a good tertiary care center, and if they are using human insulin, they'll say, Sab, I take meal immediately before I keep the thali ready, the plate is ready, and then I take insulin and then take the meal. This is common, you ask many of them. And even if you taught them well, still they will forget and they'll do that, because there are multiple other doctors in the family, around your neighbors, or in your office. They will teach you, no, insulin is to be taken just before the meal. So these things are in our hand. How do we go ahead with teaching them, educating them? Illegible handwriting, confusing IU versus U or 0, add to this confusion. For the sake of convenience, several doctors relate regular insulin as a clear insulin. This was a clear thought. When I was learning diabetology, I was told if it is a cloudy insulin, it is a long-acting insulin. If it is a clear insulin, it is a short-acting insulin. I was very happy. It was so simple to understand. Then the analogs came. Everything is clear, boss. Everything is clear. And now you are, so clear insulin may not necessarily be the long-acting or short-acting. Even Lispro, Aspart, Glargine, everything is clear. Further, patients, Aspart, Lispro with Glargine combination will be using 2 types of clear insulins. So mistaken further continued in insulin area. So insulin not properly written, insulin name of the insulin not properly written, doses are unclear, use of U is being sometimes mistakenly taken something else, insulin prescription not signed, insulin given but not recoded and signed in the chart, device to use not being mentioned, and insulin prescription sometimes gives a wrong time. And these are some of the examples, prescription errors. This you can see whether it is 80 or 8 units TDS is very difficult to understand. And various things you can see here, use of the sliding scale. And when you write the sliding scale, it's being taken something else. I feel I have another slide. The Humalog 4 units, 2 units, 6 units, Lentus 40 units, and this is HS. Now someone has cut it here. So someone has, if someone gives instead of 14, someone gives 140 units or 144 units, then it becomes too tough for, and these nurses sometimes, or even the patient, their relative, might not be really having that judgment. If you do so, what can go wrong? So this prescription are not common, uncommon, these mistakes are not uncommon, potentially dangerous. I told you, replace, it is also suggested to replace BD, non-standard abbreviations to mean the before dinner. So all these things we have to also check here. Now you see here it's very difficult for me to understand what is written here, whether it's 4 units or it's 44, it's very difficult to understand. And here again they have not written properly 100 IU insulin or what. So we have to now, how can we prevent these errors? So first thing of course is education. Education to the provider. Now this happened yesterday, coincidentally, 2 of the patients have come, both of them belongs to this lecture. And one of the patient was yesterday who came to me and he said his pen was not working. Sir, can I get another pen? I said, what happened to your pen? He said, my pen is not working well and that's why I'm taking insulin through the syringe. So I said, but your dose was around 10 units in the morning, 10 units in the evening. No, sir, I have reduced to 4 now. Since last 4-5 days, my sugars are going down. And said, can you give me the pen? He did not ask me why low sugar is happening. He was asking for a pen sample. So I said, okay, you give him the sample, but I asked my staff, you go and check that what is happening, what has gone wrong with the previous pen. He went and see pen was really not working, and he gave the pen. But I said, then how have you taken insulin for last 5 days? So he said, I went to a chemist and he gave me a syringe, I'm taking it, and it was 40 IU syringe. So it was almost 2.5 times insulin. Someone's taking 10, now it's going 25 units of insulin instead of 10 units of insulin, and he was going in hypoglycemia. That's why 10 units 3 times a day has gone to 4 units 3 times a day. Still he was getting hypoglycemia. So there are small things which we need to provide us decision support, changing the team, adopting a better policy, insulin prescription chart, regular audits are important in the hospitals. Ours is a small hospital, so we can do it through educators. Improper storage. It loses its viability when the vials were stored in a topmost part of the refrigerator door and getting exposed to the very low temperature of the deep freezer due to malfunction. This happened also even in the traveling. Many of the people, they just go to US for 3 months, 4 months, and then carry this insulin, put it in the luggage. It goes in the storage area where the temperature is not being regulated well. And by the time they reach US, it is likely that your insulin gets denatured and will not be of any use because you are at the high altitude. It goes with minus 20 and minus 30 temperature, and if the storage area is not being well regulated in the temperature, then you might spoil, and that's why you should carry it in the bag. So one should not put the insulin at the first column of the storage area of the fridge. Pen should not be stored with the needle to avoid potential air clogging. I'll tell you that. And dark places to be avoided. Direct sunlight should be avoided. Clean plastic bag can be put. If you don't have fridge, now many of the rural places we don't have the refrigerator available, so you can prepare their own fridge. And it has been scientifically proved by AIMS that it is working. So should not be putting it here. This might denature the insulin even in the storage area, in the freezer area. It should be kept at the drug area. Storage of insulin during travel, again you should use the cool thermo flask with ice, or we have also prepared a bag, a simple bag, and we have put a coolant there inside, and that we usually hand over it to the patient. So 12 hours it can really work well. So temperature regulation is important. This about is 100 IU insulin, 40 IU insulin being taken in 100 IU, so you will get 2.5 times less insulin. And if you do other way around, you will get 2.5 times higher insulin doses. Pre-mixed insulin are most commonly used preparation, perhaps in many of the part of the world, but resuspension of the pre-mixed insulin is the most important. You have to roll it down between two hands, and accordingly you should take it. If you don't properly mix it, then it might cause a problem. Cloudy soluble insulin compared to crystal clear insulin, again improper mixing has to be taken. When you take out, you have to take the short acting first, or when you take the short acting insulin first, and then take the long acting insulin, and also put the air inside it. If suppose you have 10 units, you have to put 10 unit air and then take the insulin. Otherwise, by pulling insulin every time, you will prepare the negative pressure inside the bottle. By the time next time you push it, with the negative pressure, your all short acting or long acting insulin will be pulled in the bottle, and it will get mixed with the other insulin. So you have to be careful even on those lines. Even presence of subcutaneous fat, very few nerves are there. I'll tell you what is important as far as subcutaneous fat is concerned. Before that, cleaning is important, and middle of the area moved outward. Yeah, it is important. Cleaning should be started in the middle of an area and moved outward in the circular motion away from the center, and that will help you in cleaning it better. Sometimes you use the alcohol swab and take the injection without drying. If you do take it without drying, the micro drops of that alcohol causes local irritation and burning, and there can be some scarring there in future. So one should allow it to dry up. Soft tissue infections can potentially lead to surgical intervention, uncontrolled blood sugars, significant cosmetic disfigurement. And alcohol removes the silicone. Yeah, sometimes what happens is, needle, you need the pen needle you use, or even the syringe needle, it has a silicone coverage, a silicone covering, and that gives you the smoothness of the needle. Once you put alcohol swab on the needle, many people they try to clean the needle, so you remove that silicone covering and the needle become blunt, and that is why you should not do that. Only area should be clean. So there are some pictures of infections and local irritation of at the insulin site. So cleansing is even on the top of the bottle is at most important. This is unhygienic way of keeping the dust. And then faulty injection technique, deliver insulin in the subcutaneous adipose tissue, make a lifted skin fold. So you have to have a skin fold, put it in the 90 angle. In rare cases, very thin people with BMI of maybe less than 18, you can use 45 degree. Shorter needle, 4, 5, 6 middle is less. 4 and 5 for the pen, and 6 mm for the syringes. Now important is, I'll again show you this rotation is important. Lipohypertrophy I'll cover in the subsequent slides. So faulty injection techniques have to be understood. Now all precautions to be taken those who are using insulin pen. Remove the blockage and avoid injection in the air. When you have air inside, you have to properly tap it and remove the air. If you take it with the air, you will not get the sufficient insulin, and this is important. Now this is very important to understand, and you go to your anatomy days, almost 30-40 years when we learned this. The skin thickness is on an average 2 to 2.5 millimeter, regardless of age, whether it's adult or child, gender, ethnicity, geographic location, or BMI. So skin thickness is around 2 to 2.5 millimeter. So anything more than 2.5 millimeter will end up into subcutaneous tissue, and if it is longer, it might go into the intramuscular. So insulin must be injected into subcutaneous layer. Intramuscular should not go. So 90-degree angle, 45-degree in rare cases, and shorter needles are beneficial over longer needles. Correct and incorrect way of skin fold. So you should hold the skin like this rather than holding it with all multiple fingers, because you might hold it with the muscle. So this is another thing which you have to understand. When you prick the needle, you keep when push the insulin inside, you have to keep you have to count for 10 seconds. Now 10 seconds should not be 1, 2, 3, 4, 5, 6, 7, 8, 10. No, it should be 10, 9, 7, 6, 5, like this, so that you actually count 10 seconds. And then when you put it, then the insulin properly goes. Pregnancy, people have apprehension whether we should give it in the abdomen or not. So first, second trimester, you can certainly use abdomen. Third trimester, if you have an apprehension, you can use other areas for insulin in pregnancy. When you reuse the needle, this is the second, once used, this twice used, and this 6 times used, it gets blunted. So you have to be ultra careful of using multiple needles. So we usually say, ideally you should use only once. But if you use multiple insulin injections, then you should you should see to it that it should not be more than 4 or 5 pricks per needle. Some of the people have taken insulin from over the clothings. This was utmost disgusting to know this, because people, and it might not be going also, it might be going into the skin rather than subcutaneous level, and it might be even hurting them, so should not be used. Where all to keep the insulin should avoid to the sun exposure, should not be used here, and should not be kept even here, and should be avoided even above the fridge where there is. And this is not the right place. You have to keep it below insulin suspension, and then this can be used as a proper storage if you don't have the fridge. Precipitated, plumpy, and frosted insulin should be discarded, should not be used. 40 versus 100 IU, already told you, this was a case yesterday, 65-year-old male, 40 units insulin, premixed insulin. This patient was another one who has presented with severe hypoglycemia with 32 blood glucose, and he had paralysis of right side. Of course, it got corrected with IV dextrose, but his insulin pen was not working since 5 days, and was using 40 IU instead of 100 IU and taking it. And this is the error. You can appreciate the sliding scale. Now should not be used, but still, if you see, very difficult to understand. This is 0 unit. This is 7 unit, but if it is 44 units. So if you have 200 to 250 blood glucose, you will take 44 units. So this 6U regular is looking like 60 units. So one should, this is all a published data, BMJ. So one should be, storage I already told you. When you put the pen, you should not be putting the needle in the pen on. You should remove the needle, because when it is hot, the bubble may come out from the needle, and when it is cold, it may shrink, and it will take the air inside. So that is another thing. Never leave the needle attached to the pen. Safe disposal is at most important. We usually give them the box to the needle cutter, and then you can give it to your family physician. Lipodystrophy is another area of my interest. So this is when you go on taking insulin at the same site, there is swelling. Insulin is a lipogenic hormone, and that causes lipohypertrophy. And when you take insulin at the same site, that is painless site, and then there is poor absorption, and then you have high risk of unexplained hypoglycemia and glycemic variability, and even risk of ketoacidosis. Risk is almost 40 to 50% from various studies, and higher risk of higher HbA1c, higher risk of unexplained hypoglycemia, glycemic variability, more frequent ketosis, and higher insulin dose requirement if you are taking insulin at the liposite. So we have done this glycemic variability, I told you, around 49%, unexplained hypoglycemia around 40%, and 25% reduction in the insulin doses when you switch over from a liposite to normal site. And if you use insulin multiple times, the risk increases in these. So you have, again, I'll just go away from that. Lipohypertrophy, this is the prevalence, if you see, is around 68% and 90% in sonography in one of the study. What I'll able to share, what is data from India. We have done one type 1 diabetes as well as one in type 1 and type 2 diabetes. Around 70% of the people may have in type 1 diabetes, around 37% with type 2 diabetes on insulin may have lipohypertrophy. This is one of the unique data in the world that we have used CGM. We have put insulin at the normal side for first 7 days, and next 7 days we have put the insulin, first 7 days we have put in the lipo side, and second 7 days we have put in the insulin the normal side. And you can appreciate the glycemic variability in the first 7 days versus the next 7 days. And this has been published in DTT. So mean glucose, and again I'm not going in detail, but you have Conga, you have MAGE. We are the markers of glycemic variability. They are found to be statistically significantly. ये बंद किया है कि हो गया है? अभी तक तो बंद नहीं हो रहा था. It was not. It's a power cut. I said, okay. So you had these are some of the chairperson sir. Hardly 1 minute will take. So show some pictures. So there are lipohypertrophy at the thighs. And this is another girl who has lipohypertrophy on thighs, and this is a woman. And this is again you have lipohypertrophy with some ulcerations at the site. And this is another guy. This is a lady who a mother could come with a daughter around 12 years or so, almost 8 years diabetes. She is taking only insulin only on one thigh. And this patient has come that there is a tumor in the thigh, so not thigh, the gluteal region. And this needs to be operated. So basically it was lipohypertrophy. And this unfortunate part, this man must have seen some movie and was taking insulin in the forearm. We never teach any person who's attending this meeting. I'm sure that they are capable of telling that that's not the site, but he must have seen it some movie, taking injection, started taking it almost for 5-6 years. And this is again in the arm. And this is again abdomen. This is bruit in the abdomen. And this is yesterday's case. I have a second case. One was that 40 and high wala, 100 wala story, and this is the another patient who came yesterday. Severe lipohypertrophy on both the sides. But one side, even they had some abnormal, possibly using it. This man was an adult person taking insulin almost in 19 years. And no one has taught him, and no one has seen the insulin site. So lipo causes increased risk of glycemic variability and explain hypoglycemia. So every clinician should make it a point that you should be seeing the insulin injection site regularly, at least once in 3 or 6 months. And if you have insulin lipohypertrophy, you should ask the patient not to take insulin there for at least 1 year. At least 1 year. So start thinking lipo, think lipo. To summarize, insulin prescription error are commonly seen and are preventable. Lipohypertrophy is a common and preventable error, but an underdiagnosed complication of insulin injection needs awareness for all of us. It is important to provide education about insulin and method for delivery. Final answer is education, education, and education. And I'll always appreciate Dr. Laurel Hirsch, who has type 1 diabetes almost now 55 years on insulin therapy. He was director of one of the multinational company based in US. And then he actually stimulated me to go for the data on this line. Last slide, which I show in every meeting, is cut the fruit and not the cake to celebrate any occasion. There's another part of education. So instead of cutting cake and cookies for pastries for celebrating your birthdays and anniversary, cut the watermelon. You have good pineapple here, you can cut that. Or you can have papaya. So cut the watermelon, papaya, and fruits to celebrate the occasion. Rather than cutting the cake, which is a hydrogenated fat, and that will give you another risk for atherosclerosis. And we all GLP-1 people, NSGLT2 inhibitors will be enjoying that. So better if you want that your patient should be protected, this could be another part of education. With this, I stop here. Thank you very much for patience.